Alright, inflammation and infections in chapter 35 is where I'm going to start. Infective endocarditis is an infection of the endocardium. Strep or staph are the most common infective organisms. Infective endocarditis typically occurs in those that abuse IV drugs, have had any type of valve replacement, have systemic infection, or those with cardiac defects of the heart structure. Ports of entry for the microorganism, the oral cavity, any type of infection or skin rash, or surgery and invasive procedures. Clinical manifestations occur within 2 weeks of the bacteria infecting the endocardium. We typically see a fever of 99, low-grade fever, to 103. New onset murmurs, petechiae, Osler's nodes, and positive blood cultures. Remember in the older adults that we might not see this fever. Heart failure is the most common complication of infective endocarditis. Arterial embolization is another major complication. That's when fragments break off and are carried throughout the circulation. In order to diagnose infective endocarditis, an echocardiogram is typically performed, positive blood cultures, and a new regurgitant murmur is present. Non-surgical management, typically antimicrobials are given. Anticoagulants should be avoided. Anticoagulants do not prevent fragments from breaking off, and they should be avoided because of bleeding. Surgical management can be done. Prophylactic treatment before any dental surgeries should be given for these patients, especially if they've had a history of infective endocarditis or if they've ever had a prosthetic valve. Pericarditis. With pericarditis, we have acute and chronic. Acute pericarditis results from inflammation or alterations of the pericardium, typically short in duration, 2 to 6 weeks. But the individual can have recurring attacks of acute pericarditis. Acute pericarditis is associated with infective organisms and after a myocardial infarction. Chronic pericarditis occurs when there is a thickening of the pericardium. The thickening prevents adequate ventricular filling and leads to heart failure. Chronic pericarditis can be caused by tuberculosis, radiation therapy, metastatic cancer, or renal failure. The individual that presents with chronic pericarditis typically has substernal precordial pain. The pain is often aggravated by swallowing, breathing, and coughing. Pericardial friction rub can also be auscultated, and these patients will have an elevated white blood cell count. Interventions. We want to make sure we are providing pain management. Pericardiectomy can be performed. We want to look for any type of pericardial effusion. That's when layers of the pericardium fills with fluid. And we also want to look for cardiac tamponade. Cardiac tamponade occurs when there's too much fluid in the pericardial cavity. Cardiac tamponade is an emergency. We want to make sure that we are noting any jugular venous distension, paradoxical pulses, muffled heart sounds or distant heart sounds, hypotension, and a decreased heart rate. Pericardiocentesis are typically performed for treatment. And after the procedure, we must monitor the patient for a recurrence of cardiac tamponade. The next disease process that we'll talk about is cardiomyopathy. Cardiomyopathy is a disease of the cardiac muscle. It's not uncommon for the cause to be known. The patient can be symptomatic or asymptomatic for months or years. There are 4 different categories belonging to cardiomyopathy. I do want you to know that cardiomyopathy can have a familial association, and it can be autosomal dominant. And typically the ventricles are going to dilate or hypertrophy. And symptoms are typically those of heart failure. Non-surgical management, we provide drug therapy. Surgical management would be a heart transplantation. The criteria to meet that heart transplantation, the individual must be less than 65 years of age, be given 1 year of life expectancy, be class 3 or 4 on the heart failure list, absence of active infection must be present or must be noted, stable psychosocial status, and no evidence of current drug or alcohol abuse. For heart transplantations, the nurse must watch for tamponade occurrence. The transplanted heart is unresponsive to vagal stimulation, so drugs are given to titrate the heart rate immediately postoperatively in order to maintain cardiac output. So whenever these hearts are transplanted, they're unresponsive to the autonomic nervous system. Orthostatic hypotension can occur, so we should caution the patient on that. We want to monitor for signs of rejection. Signs of rejection for heart transplantation can include shortness of breath, edema, abdominal bloating, AFib or flutter, and hypotension. It's important to remember that infection is the major cause of death for these individuals, so nurses must use good hand hygiene, and we also need to teach these patients and stress the importance of diet, hand hygiene, and adhering to drug therapies.